a pleasure to be here today. And thank you to my friends and colleagues that they are online. In the good morning for some, good afternoon, good evening. I have my drink, that's my coffee. Please grab your drink. Could be sometimes the wine or beer, and enjoy the presentation. And thank you again for the invitation. So today I'm going to talk about the medical alternative treatment for male pattern or female pattern of hair loss. I don't have any conflict of interest. I saw this photo in a bank a few years ago, and I really like it because it's when we see a patient with hair loss. So we cannot predict the future of the hair loss of that particular patient, but we can help the patients to plan for it. So that's very important, how we can talk with the patients and plan for them something about the hair loss for the present, but also more important for the future. And the objectives of the presentations are, I'm going to mention general aspects of the medical treatment and also the male pattern of, let me see, you remove here, male pattern or female pattern of hair loss. The part one is I'm going to talk about medical treatment, and we will have time for a few questions. And then we will go to the second part, alternative treatments for hair loss and questions. This time, with the second part also, I will include about the wound healing for the PRP, a wound healing for laser therapy, because we start with that, and with that learning and knowledge, we went to the hair loss with those type of techniques. We're talking about male pattern and female pattern of hair loss. That is important to mention, and the patient needs to know that there is no miracle treatments. We don't have the one treatment, this patient will take this medication one time and everything will be okay. No, unfortunately that don't exist, and we see this every single day, unfortunately. So we need to be careful and need to educate the patients about that. And also we need to tell the patient this is a progressive disease. Even that we have good response, good treatments, still the progression of the alopecia will continue in the years to come. The general aspects, we know for sure that male and female pattern of hair loss as the most common type of hair loss affecting men and women around the world. And hair loss, it's very important because we need to have the consultation and evaluation with the patient. We cannot choose a good medical treatment for the hair loss patient if we don't have the most important diagnostic. I see many patients, even young patients, losing hair, young patients like teenagers or young adults, and immediately, no, this is the generic alopecia, I'm going to give you finasteride or minoxidil, and we don't know yet exactly the right diagnostic. We need to keep in mind that they're close to 100 hair loss causes, so we need to be very careful about the diagnostic and then choose the right medical treatment or surgical treatment. And pictures, that's very important because the patients with hair loss, they don't remember when they were before sometimes the treatment or how the progression of the hair loss. So we recommend the patient, if we don't see in consult, take photos, send the photos, or the most important, the consultation face-to-face. But we know the pandemic now, but at least we need to have one communication or two way to communicate with the patients. According to the medical treatment, it's important, I want to mention later again, it's review anything and details about the pros, cons, and side effects. I don't think we need to be afraid to tell the patient possible side effects with finasteride, dutasteride, or minoxidil, etc. And the patient should know. If nothing happened, perfect, everything is okay. But if something happened, the patient should know, and let us know. Expectations. I think this is important because the patient, many times they think that with the medication, everything will be okay. There is no surgery, etc. And every case is different. And we need to customize or plan and technique for that particular patient. And I tell my patients, talking about medical treatment, they have in my two objectives. Number one, stable your hair loss and some regrowth. I saw patients that they said 1 year later, Dr. Perez-Meza, I see nothing. I don't see results, medical treatment, etc. And I compared the photos 1 year before and 1 year now. And they said, well, we can see that you didn't lose too much hair. So that's some part of the objectives that we need to get with the patient, at least stable hair loss and some regrowth. I need to tell the patients. And we need to make a plan, as I mentioned before. You need to make a plan for the present and for the future. And the patient need to know that, because if not, the patient, they take the medication, and I, like you, probably hear patients, I took Propecia 3 months, I didn't see nothing, and I never took again. I tried Minoxidil 2 months and nothing. That's wrong, because the patient didn't wait the time need to see if they're going to work for that particular patient, 6 months, sometimes up to a year. So make a plan for that particular patient. And again, it's a progressive disease, and we don't have the crystal ball, how it's going to happen for that patient, but we know that they have a progressive disease. I'm talking about, again, teenagers and young adults. I see more and more patients, younger, losing hair. So we need to be very careful, do a very good evaluation and diagnostic before treating them with finasteride and minoxidil or another PRP until we have the right diagnostic. And thank you to my good friend, Dr. Ken Wichani, that gave me this slide. And talking about the treatment option for androgenetic alopecia, there are two main groups. Number one group will be the follicle growth stimulators. And today I'm going to talk about topical minoxidil, a little bit of bimatoprost. I'm going to mention low-level laser therapy, platelet-rich plasma, and the other group is the androgen modulators, finasteride, dutasteride, even a little bit of spironolactone. So there are different mechanisms of action, and for that reason, the combination treatment works much better than one single treatment. Today, I'm going to talk for the medical treatment, the main two medications, FDA approved, minoxidil and finasteride. I don't have any conflict of interest with the Pfizer. I would like it, but no, zero, nada, or Merck to promote the medications. And for male pattern of hair loss, we have the topical minoxidil, 2%, 5%, FDA approved. The solution, it was the original formula, but the foam, it's much better because they have no propylene glycol and also less irritation and better absorption, less greasy. But for the patients, sometimes the budget is too difficult, so they can buy it because it's a little expensive, plus finasteride. So I recommend at least solution to start with a treatment. And we have here oral finasteride, the Propecia, 1 milligram daily, that was approved in 1997. I will mention, and the side effects. Last week, we discussed with Dr. Sarah Wasserbauer the side effects, and the study showed that 1.7% of the patients in the study, they have side effects, I want to mention soon, and versus 1.2% of the placebo patients. So it was 0.5 difference between the side effects and with the finasteride and the side effects with the placebo group. Also, sometimes I use the low dosage, 0.25 milligrams, that I'm going to mention in the next slides. For this one, everybody knows this Norwood classification. Just a little, remember our good friend and mentor, Dr. Otto Norwood, that died 2 months ago. Condolences for his family, but his legacy for the ABHRS and to us, we are very grateful for what he did for hair restoration and hair loss patient. It's just condolences for the family and the ABHRS member for he died. But talking about male pattern of hair loss, we know that DHT is the bad guy. DHT, the bad guy, because you can see here, we have healthy hair, thick hair, active, growing, and fully pigmented hair. But with the action of the DHT, we can see the progressive start with a hair thinning. Thinner, shorter, and less pigmented hair, and then we get the miniaturization. This is more related for male pattern of hair loss, but DHT, testosterone is most likely not the principal factor in female pattern of hair loss. So I'm going to talk a little bit later. Finasteride, again, it was approved in 1997 for adults in IBITS 5-alpha reductase type 2. The dosage is 1 milligram daily. And you can see the hair, the growth up to 2 years after the start, and decreases both the serum and scalp DHT level. And this is very important question with the patient, adults taking Propecia, and the wife probably going to be pregnant. What happened with the finasteride? When I tell the patient we don't have too much data about any congenital issues with the baby, with the patient taking the finasteride, the wife is pregnant. So I recommend sometimes discontinue the medication and restart the medication after the delivery. Also, it's important to adjust the PSA levels the patient is taking finasteride, because we know that at least 40% or 50% is going to be decreased, and the patient should know if they're going to do PSA test for that. Finasteride, again, 1 milligram oral. Talking about the brand, is better than the generic. I have been also patient for hair loss patient and hair surgeries also. And I have been taking Propecia for probably 20 years, 22 years. And no question, and I have the experience with my patients in Spain and the patients in the European Union, even patients in Mexico or in the United States, that the generic sometimes is not the same one that the brand from Merck. So I try to advise the patient, if the project it's good for them, try to get the Merck, the brand from Merck versus the generic. If not, you can also recommend to buy from Merck Proscar 5 milligrams, and they cut in 4 pieces and take 1 daily. So in my experience, again, in summary, I will recommend better the brand than the generic, because they have several issues in several companies about the generics. And again, I mentioned sometimes 2.5 milligrams daily, a quarter of the milligram, but the study show 17% less hair counts versus 1 milligram. Yes?
Naeem.
Oh. This is an excellent slide that just to remember what Dr. Sarah Wasserbauer mentioned last week also. This is the global photography that a 5-year finasteride study in men 18 and 41 years old. You can see that 90% of the patients in the study gained or did not lose hair, that the patient took Propecia finasteride, versus 10% that lost hair. So that's important, because we need to tell the patient what the expectation with the treatment. It was Dr. Keith Kaufman published this in the Dermatology in 2002. This is also part of that study that was discussed last week too with Dr. Wasserbauer, the finasteride hair count data. This is the 5-year, this is the placebo. You can see after 1 year it started decreasing and negative, and 5 years later is minus 240 hairs, versus the patient with the finasteride, you gain 277 hairs. So that's important for talking with the patient, what they can get from taking the finasteride. But now we have the finasteride side effects, and there is, according to the study, no significant effect of the sperm, but they can reduce the finasteride, the amount of semen. Erectile dysfunction has been mentioned also, but talking with a good friend neurologist, and they said in the general population, 30 to 40% of the male persons can have erectile dysfunction. It doesn't mean that no disease, no medication, 30 to 40% they have it. So that's important to talk with your patient. You're going to prescribe the medication, ask about any of these issues prior to take the medication, because if not, you cannot ask the patient, and the patient later on contact you and say, Dr. Perez-Meza, I have issues. I don't have erectile dysfunction, but that looks like it's the medication. Probably it wasn't, because the patient had before. And also finasteride side effects, libido, gynecomastia, depression. But when I put here questions, because keep in mind that our patients, unfortunately, the hair loss patient, they have anxiety and they have some type of depression. If we don't check very well that particular patient, we're going to prescribe, and the patient have depression, probably the medication gives some extra depression. We don't know, but the patient will be with several issues, and they have some legal issues against Merck for that particular thing. But again, the patient may have depression as one of the symptoms for hair loss. And then the patient is taking the medication, everything is good, but behind doors, in the intimacy with his partner, they have some issues. So the patient asked me, I say, Dr. Perez-Meza, I like my hair, finasteride working very well, but behind doors, I have some issues. And I said, well, there are two plans. I will recommend plan A. If you think it's gonna be difficult for you that night, just say, sorry, darling, I have a headache. And then probably it's gonna be with excuse, but they say the night for you. Or plan B could be the blue pill, Viagra. I check with one of my friend urologists and recommend me, tell the patients, take Viagra, and that will help you with this. But that's true story. That is not, that can make happen. It does some recommendation for the patient. But also we can read and see the internet or social media, post-finasteride syndrome means patients, they took Propecia, they took finasteride, and then the patient discontinued the medication because they have side effects, and those side effects will persist. So they have a lot of other issues. Again, talk with your patient about possible side effects. Some colleagues, I know that they have finasteride consent form. You tell the patient the pros, cons, and side effects. They have a form, they read it, they sign it, and you know that they learn from you about the medication. And the follow-ups, it's important. I have patients that they no surgery, just the medication. So I follow minimum 6 months, but the patient is difficult to travel from another city, town, or even country. So usually we can do 1 year follow-up. That will be great. But also keep contact with this patient with any issue, tell them to contact you for your advice. Talking about the finasteride persistent side effects controversy, yes, unfortunately, post-marketing reports of side effects persisting after the discontinuation of finasteride have appeared over the years. Even UK and the Swedish regulatory agencies and others add notice of these reports to the package inserts for finasteride. So we need the patient know about possible of these side effects. And also many journals have been talking about this. Sometimes we review, for the HRSP, we have some different, even we have a committee for the finasteride, etc. And many times it's just, these not very well-oriented articles about the persistent side effects with finasteride, but we need to know and tell the patient. This is just one patient that they took finasteride for 1 year. You have good improvement, especially in the front area. They have very good response. And now talking about Minoxidil. That's the other medication FDA approved. Is for men 5%, but also 2%, 5%, and for women too. I'm going to talk about a little bit of both because the action, etc. And the solution is 5% only, as I mentioned. The mechanism of action is a little, they have different. Many times they said it's prolonged. The anagen phase of is short, the telogen phase. We don't know exactly the real mechanism of action. Another one is up to regulate the vascular endothelial growth factor, which promotes the anagen phase, also increase the blood supply of the scalp, etc. And the side effects that could be for men and women too, irritation, but now with the propylene glycol, that is not, they can help, that is not in the foam, that reduce the irritation. This can produce with a solution this problem, and the patient will complain. Hypertrichosis, yes, we have seen several patients with the Minoxidil, and you can see facial hair that sometimes require any hair removal. This is important. Shedding between the 2 to 8 weeks after the start may happen. It doesn't mean that it will happen all the time, but may happen, and the patient should know about this. We need to tell them, it not happen, excellent, but it happened, they know. Again, this is the Rogaine formulations, 2% solution, 5% solution, and 5% foam. Just to summary here, if the patient have hair, I will recommend much better. Well, they have hair loss, but they have some hair. I don't recommend the spray because some patients, they you do boom, 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 and then spend 1 minute and finish, and that's it. But the result is not the same. So I recommend for those patients to use the dropper and take the time. This is better, direct application. Twice a day, it's my recommendation according to the studies. Again, the risk of the facial hair, and sometimes will feel some itch and burn, some messy, patients complain. But again, the foam is much better, less irritation, better absorption, and still the complication could be similar. So the patient will tell you, but the most important is to teach the patient to apply. When you ask your patient how long or how he or she applies the minoxidil, you will be surprised that don't take too long. It's a big area and they don't do the right thing. And I think we are partially responsible because we didn't teach them. So again, we need to teach the patient, take your time. You don't need to hurry to apply the medication, especially you have a patient with hair loss from the front to the back. Even they're going to use more than 1 cc. I said, no worries, use more, but you need to reach all the areas with the scalp. This is very important because, again, if they don't apply correctly and the time and the place, the medication, it's not going to work probably. And there will be good results for the patient. And this is a global photography of the patient, one of the studies actually. This is 5% minoxidil with the foam. And you can see baseline and good result in the crown 4 weeks, 16 weeks later. Talking about the medical treatment, again, I mentioned the combination treatment. Now, this is a combination treatment effects of finasteride, 1 milligram on hair transplantation. We did a study, Matt Levitt, Marco, Verusco, and Craig. We did a study in 2003, was multi-center study that we published in 2005. I send you a copy of this article, but this is a very important article because we compared these two groups. It was 1 year double-blind randomization 1-on-1, and we compared patients with finasteride 1 milligram daily, 40 patients versus placebo, 39 patients, but both groups, they have hair transplant surgery. Usually more in the hairline, front, and a little bit of the mid-scalp. This is the result. You can see some response here, the placebo group, absolutely, because keep in mind that we place some graft in the target area, but the better results show in the finasteride group. Pretty much 90% of the patients, they have some better results versus the placebo because we have the finasteride and the transplant surgery. Just to show a few cases of that, it was small cases, 1,102. You can see most in this area for the transplant. This is placebo, and you can see 48 weeks later. Still you have some decent growth, but only the patient lost hair, and you can see thinning in this area. In the other side, you have, you can see the finasteride patient. It was very small case, but we used at that time the multi-unit graft and micrograft, and we placed pretty much the graft in this particular area, but it has great response with the finasteride plus the surgery. So here is more just summarize here at week 48, hair count increased an average of 32 hairs when comparing finasteride versus placebo. And the conclusions, obviously the importance of this, it's 48 weeks post-operative finasteride group had significantly greater hair counts than the placebo group. Obviously, the most important part of finasteride was to preserve that non-transplanted hair, but also we noticed that helped, and I, as a patient, I noticed that the finasteride helped me to my transplanted hair too. talking about, but again, talking about side effects, patient, they say, Dr. Perez-Meza, I don't wanna take anything. If I wanna put something, I will be more than happy. So there's a real concern with patients. So now Dr. Amin Mugese asked me about topical finasteride. Well, they have something new that is working even for several years about topical finasteride. And this is one of the studies. It was 1 week study, but it was just pretty much to evaluate the plasma, the DHT was reduced, similar percentage of topical solution versus the tablet. It was pretty much the same to reduce the plasma DHT for the absorption. That was a good thing. And then we have this is a systematic review, 7 articles about the thing. And same thing, obviously they found both scalp and plasma DHT. It was decreased with application of topical finasteride, no changes in serum testosterone. Also, the conclusion, preliminary result on the use of topical finasteride are limited but safe and promising, and continue to research into the drug delivery. That's very important. How's going to be the absorption and the ideal topical concentration and application frequency, because they are using now 0.3, 0.1 for the topical finasteride. So there's still a lot of research, but I'm glad that we can see something in the near future for another option for our patient with hair loss. This is part of another photos with the patient with combination treatment, finasteride and minoxidil. You can see the patient before baseline and 12 months later, and then the patient before and 10 months later. So you can see the difference between the baseline, and they will have good results with a comparative treatment. Again, combination treatment, you have here this patient. I've shown this patient, they have 1 surgery, this particular patient, no medications at all. So I saw the patient, the first thing what I did, put the medication, provision, minoxidil, 1 hair transplant surgery. I just work in the hairline, and you can see the difference. Just the hairline and the front, it was probably around 1,800 grafts, close to 2,000. But you can see that good result in the crown with a finasteride and minoxidil. I didn't touch the crown, and this is all the medication. So again, the combination is much better. Dutasteride is another medication we start to use more and more. It's not FDA approved for alopecia. That blocks type 1 and type 2 of the 5-alpha reductase. Is 3 times more potent inhibitor than type 2 compared to finasteride. And again, the dosage that we use is 0.5 milligrams, is near complete suppression of the DHT. So that's great, the patients show better results. And I actually recommend the patients different options, 0.5 milligrams daily for 3 months, and then see how they respond. And because the half-life is longer than finasteride, I can recommend every other day, twice a week, or sometimes finasteride all the week, and dutasteride once a week. So there are different options. And those options will be the oral and also mesotherapy. You can see the patient started with 0.5 milligrams of oral dutasteride, and you can see 4 months later, they have great response, and the density was much better for that particular patient. Also, the use of mesotherapy, the injection in the scalp with dutasteride. This is a report of Dr. Ceseda and Sergio Bano. And you can see the patient, this is a male, but they also use for female patients. And you can see there are 3 treatments, baseline, 3 months and 6 months. And you can see great results here after 6 months of the treatment. Obviously, those particular patients will need to follow up with the treatments. Female pattern of hair loss is totally different, obviously, than men. Hair loss in different patterns and more diffuse. In women, 40 to 50% is not related female pattern of hair loss. That's important to discuss with the patient, and then to see what we can offer to those patients. But diagnostic is very important too. 10, not to have an absolute aerosol body. It's not like the male patient, is more than a thinning for the female patient. And the reduction in density of the top and frontal areas with retention of the hairline is pretty much what we see with the female patients. And one of the most frequent areas that we can find with hair loss is the widening hitting the central part of the scalp. But again, the androgen's role in women is not completely understood. Women can have baldness in the presence of normal and high androgen levels. So the pattern is different in women and no complete areas of baldness, and don't respond equally as men do to anti-androgen therapies, except if it's a woman, they have hyperandrogens, they can be treated with finasteride, or patients with post-menopausal, they can be treated with finasteride too. But this just to show the Ludwig classification, one with minimum hair loss for female patient, two, a little more widening in the middle, and three, you have more areas with hair loss. For the medical treatment, I just mentioned the topical Minoxidil, 2% to 5%. But now I just send you an article about the oral Minoxidil. I think with Dr. Rodney Sinclair in Australia, he's just starting to recommend and did some studies for female and male pattern of hair loss with oral Minoxidil. You can start with 0.5 milligrams to 2.5 daily. It's off-label, obviously, but you need to monitor your patient regarding to decrease the blood pressure, also some edema in the lung area, and also edema in the legs. So you need to monitor for possible side effects with the patient, but will be an option. Spironolactone could be another option with oral Minoxidil, will be between 50 to 100 milligrams daily. That may help. And also, again, I already mentioned the finasteride for some particular patients. Just to show this patient, I show this patient, she had a surgery. You notice here's a little scarring, she had an infection. I saw the patient with no treatment at all. So I would recommend first that the medication, Minoxidil, it was, topical medication with Minoxidil, 5%. And you can see the results 1 year later. And then I did the surgery, and you can see the surgery 1 year later and 2 years with the treatment. So the combination helped many of our patients. So the note to take home of this first lecture will be, we're educators. We need to educate our patients about all what they can do, but at the end of the day, the patient will take with no pressure the best decision for the patient. Male pattern and female pattern of hair loss are totally different. The medical plan for the present and the future, combination treatment is important, as I mentioned, and treatment expectation, what the patient, the expectations are related to the treatment, and that can give us better options for them in the future. So we have, I think, a few minutes for questions and answers for this, and then we go to the next presentation.
Thank you very much, David.
I have a question for you from doctor. She is saying that, asking that can oral finasteride be prescribed to women with high testosterone levels?
Say it again, I couldn't hear.
Can oral finasteride be prescribed to a woman with high testosterone levels?
High testosterone.
Starting the question. Say again, I couldn't. Let me just put my, let me try this. Okay,
he's saying that can finasteride be prescribed to a woman with high testosterone level?
Well, yes, I think yes, but the most important is the patient has some hormonal issues. The first what I do is check the levels, and then I send them with the endocrinologist to check if they have any additional issue. And then if there's no additional issue, we can try with the patient. But again, most of the patient, the androgen, yes, could be high. And that's one of the particular options to treat the patient with finasteride. Yeah.
Secondly, I have seen.
What would be?
Yes, Dr. Irfan, please.
What would be the convenient dose of finasteride for women?
Well, the dosage for, you're talking about the dosage for women?
Yes.
Well, obviously they have had dosage. Actually, when I work with dermatologists and they recommend a little higher dosage, starting with 2.5 milligrams daily for women, pretty much postmenopausal women, or it depends, again, they have androgens level high, they can be treated also, even though they are not in the puberty, in the menopausal, yeah. So anything else? Or we
David?
can go to the next? Yes?
I have seen
I have a question.
oligospermia taking finasteride, and they came up later on with oligospermia. What do you say about that? Is that related to finasteride, or it is something which was there before that?
Well, it's a very good question. And usually, even I have colleagues that we recommend to take do a test, sperm test, even before starting finasteride, because some patients, you will be surprised, may have decreased the sperm even before any treatment. So if we don't do this, probably the patient will have that issue during the treatment with finasteride, and we will say, oh, because it's the finasteride side effect. So it's better recommendation to do test if the patient will try eventually finasteride for some patients. Yeah, I will do the test first.
I have a question.
Okay.
Yeah, probably one last question and we will finish. And at the end, more questions, please.
Okay.
Can I ask one question?
Yes, please, Anil.
Yes, my question is that do we know the mechanism with which finasteride would lead to any kind of sexual disability? Because as far as my thinking is concerned, it is supposed not to harm the testosterone. It is supposed to stop the dihydrotestosterone, which is not needed in any sexuality anywhere. So is there any debate on that? Is there any discussion on that can happen? How does finasteride even harm sexuality?
Can you say that? I couldn't, yeah. So
Yes, I can clarify.
My question is that
Let me clarify the question, Dr. Anil. Let me clarify the question.
yes, please.
Dr. David, he is asking that is DHT is responsible for sexual dysfunction or testosterone is responsible for sexual dysfunction?
Well, that's according to this, obviously is a DHT. According to this, the DHT.
Dr. David, my question is that
Probably there is more and more studies that usually they try to look for these issues, especially with the side effect that you mentioned and legal issues. There is more research right now to find more details about this finasteride and everything, but it's more the DHT,
so
than the testosterone.
DHT
testosterone
has a role in sexuality.
Just one question, one comment. Usually the patient that taking finasteride will have decreased the DHT and increase, according to some studies, 18% testosterone. So that's what happened with the patients taking the finasteride. Yeah. Okay.
Yes. So
let's move to the other presentation.
Yes.
And if anyone has some question, he can ask like in chat, and we will answer later on. Okay.
Yeah, we can have another session at the end. No worries.
Yes, we can have another session for questions. Thank you very much. Go ahead, David.
Excuse me. My question is that finasteride is more effective as compared with the finasteride or not?
I can hear. Can you ask the question?
Dr. Hanif, listen to me. Dutasteride actually blocks both the things, type 1 and type 2 and type 3 as well. But dutasteride is like off-label drug, and what we are talking about the finasteride, which blocks like type 2 5-alpha reductase, and that is another debate we can discuss in the chats, and let David go for another.
Yeah, but just to finalize that comment, yes, no question that dutasteride it's much better, more than 90% of blocker versus the 63% of finasteride. It's 3 times more potent than finasteride, dutasteride, is as I mentioned in my presentation. Okay, perfect, thank you. So I'm gonna continue.
Yes.
Now we're going to talk about the alternative treatment for male pattern of hair loss, no conflict of interest. But then just to show this, this is FDA, because somebody asked me, David, are you going to talk about exosomes today? And I said, no, because there are some still, it's new information. We need to be sure we're going to present to share or so with the colleagues. And then also FDA in July, a consumer alert about regenerative medicine products, including stem cell and exosomes. So hopefully in the future we'll have better information, but not today. I'm going to just send you this consumer alert. I want to say thank you again to my good friend Ken Washanek, because we were talking about cloning, and I said, David, yeah, we have cloning. I said, why are you talking, Ken? And he sent me these 2 slides, and you can read the here. They said cloning now available, non-surgical in 1 hour. I said, wow. Excellent. And the second slide, you can see here that they said hair cloning now available in 3 weeks. You will have the hair growth and FDA approved. It sounds like it's too good to be true. Obviously, it's not true. So those are some examples that we need to be careful with the patient, because they are misleading the patient about this. As today, I don't know, but I have seen and read anything. We don't have cloning hair cloning in humans yet with studies. So what we have is hair regeneration studies, and I'm going to show some of them today. Thank you, Dr. Ken, because he gave me this particular emerging therapies for hair loss. The research is growing, and that's good. We're looking for more options for the patient. And they have some 4 groups besides what I mentioned before: follicular cell culture, autologous fat tracker, I'm going to talk today, prostaglandin, there'll be macropros, topical androgen blockers that I already mentioned, dutasteride and finasteride, and JK inhibition, for example, that they use in alopecia areata. But I'm going to talk first low-level laser therapy that usually is approved for FDA for hair loss, but also we did studies and wound healing, and from there we learned for the hair loss patients. Low-level laser therapy is not new, has been since 1964. Dr. Mester in Hungary, he was the first one to describe, and the hair growth information in 1968. FDA approved the treatment for hair loss in 2006. And we did 2 studies about laser therapy for hair loss with Matt and Marco Berlusco. And also we did 2 studies for wound healing in 2004 and 2006 after hair restoration. Unfortunately, the studies that we did only included the Fitzpatrick class 1 and 4. We excluded the Latins and African American that we have light brown or dark brown skin or black skin. So what I recommend to my patient, you're going to use laser therapy, increase the time. Instead of 20 minutes, I go 30 minutes because it's going to be better to penetrate this type of color of skin. The combination treatment is much better. And again, same thing, permanent treatment. For the first one, in the wound healing, we use the laser therapy in the postoperative period after hair transplant surgery. We did the study again with Matt and Marco. We have here, we have, you can see this photo. We covered the half after the surgery. We covered half of the scalp with the patient. The patient received the treatment of the laser on this side in the day 0, day 1, day 5, and day 10. And also we have the hair wash before each visit and 20 minutes, the laser treatment. This is the patient that they have no laser and the patient with the laser. You can see a little less the scalp formation, the redness and the swelling. This is a patient, they have addition of the graft site, is a wound dressing with Cooper peptides besides the laser, and you can see the patient 11 days post-op with the minimum redness and swelling and minimum scalp formation. And actually we continue to do for postoperative patient, this treatment with laser therapy. For the donor area, we did a study also with Dr. Carlos Puig and Wynn Andrews around 2006 and presented in 2007 data as HRS for the donor area, decreased the pain, the redness, and the swelling in the donor area, this particular patient with a donor strip case. This macro photography, 11 days post-op, you can compare laser therapy at the top with no placebo. At the bottom, you can see minimum redness or swelling or no scalp formation versus the placebo side of that particular patient. I'm talking about the laser therapy. They have different devices, and again, compliance of the hairless. It's very important because the patient needs to follow the direction from us, what we're gonna do. And so this particular device is for the office, is the harmonic that we used years ago, but they have another devices at your office. And it's good for your office because you have the patient cautive in your office, you can see the follow-up, you can see the progress of the patient, any questions, or any another thing that you would like to show your patient at your office. Any other treatment that you can do, that's a good thing. This was a indium gallium aluminum laser, 670 wavelength, 30 diodes. It was a rotation device, visible red light, and class 3A. But they had different devices, no conflict of interest with this one or the other one, depends the patient, different the manufacturer. And I say, actually, we discussed last week with Dr. Sarah Wasserbauer that, and I recommend that you need to follow the manufacturer guidelines about the treatment, the time, and the period, because it's going to be different, because different watts, different diodes, so we need to follow those things. But the most important here is over the counter. Some devices, obviously not this one, but the other ones you can buy over the counter. And what happened? Well, the patient many times, they don't see the doctor, they just buy the device, they do the treatment at home, and then what happened? He's not happy. 3 months later, they contact you. I said, well, what happened? Well, I tried laser therapy, but I'm not happy because I don't see results. But unfortunately, didn't see the doctor, no previous photos, not good compliance to the treatments. So it's very important to convince the patients to see you for good evaluation and good treatment and recommendation for those devices. This is a patient, female patient with laser therapy. This is the results months later. And another patient, this patient had previous surgery, and then they had the recommendation for the laser therapy was the harmonics that you saw. This is part of the article that I forgot to send you, Mughis and Irfan, that we published on laser for hair loss and wound healing too. This is part of what the studies, day 1 and 6 months, sorry for the Spanish thing, but you can see the patient in the baseline, and you can see the patient with the laser therapy 6 months later, look a little thicker, more covered in some specific areas, but that got some results. Obviously, you need to continue with the treatments with the patient. And talking about the autologous growth factors has been very informative in the last years. And then for the wound healing and the PRP for hair loss, I'm going to start here. Mention that we started working with 1999 and 2003. I received 2 grants, and with MHR, and also start research about the hair loss, wound healing, and it was for related to the growth factors and the PRP in 2003. But talking about the growth factors, they were discovered 40 years ago. That's not new. Probably the last 20 to 30 years, they have shown a key role to initiate all human wound healing. That's very important because they were starting to use the dentists. They started to use in patients, and it was probably 25, Dr. Marks, one of those pioneers using this device. This is part of the study that I did in 1998 to 2000. You can see the post-operative patient. We took biopsies. This is one of the biopsies. It was this mini graft, multi-unit graft that we evaluate. Day 14, we did the biopsy, and we can see the transforming growth factor beta. He's surrounding the follicle, and then the activity of in 3 areas. So one of the studies showed that we have activity growth factors here in this area, in the middle, and the superficial area too. So we found that the upper third, we found growth factor activity. And the growth factors pretty much the platelet, transforming beta 1, beta 2, epidermal, vascular endothelial, and those are found in the platelets. Platelet-rich plasma has been a little discrepancy, but according to what I know, what I read, and what it is information, that's the volume that you have a baseline, and to be 4 to 5 times from the baseline, above the baseline, to be PRP. That's one of the things that we know. And the benefits, obviously, speed the wound healing, decrease pain, decrease redness and inflammation, talking about hair transplantation, decrease infection, and also we talk about later about hair growth. Applications in plastic and reconstructive surgery, too many options after cosmetic surgery, retidectomy, blepharoplasty, orthopedic, tendinitis. We have a lot of professional players, soccer players, that they injected PRP, cardiac surgery, etc., etc. We found a lot of application of this. But talking about the growth factors, one of the keys is the centrifuge, as I mentioned in a few minutes, because that's going to be the best quality of the platelets. One thing is you can get the platelets, and the other thing is good quality, good response, and it helps in your cases for wound healing and hair loss. So this is a laboratory centrifuge, one single spin, multiple sterile barrier entries, a greater potential product contamination because you remove, extract, back again, spin, and they found some studies that 30 versus 70% decrease efficiency in recovery platelets versus the automated machine. You have in the other side here, you have the machines, automatic machine, double spin for separation and concentration. Is like you have your Lamborghini and you have your centrifuge. This centrifuge is from actually probably 2003, 17 years ago, but they have many devices. It was automatic, 13 minutes, and you can get the PRP and the PP. So they have many devices around the world, just you need to follow the directions of the manufacturer for the case. And this is one study that we did for the application of the growth factors in the donor recipient area and the storage solution during hair transplant surgery. And we include 10 patients, and we do PRP and PP, and also storage solution, donor and recipient area. And this is what we already spin, and we can see here the PP, the platelet pool plasma, and then according to this machine, this is here with the platelet-rich plasma, and this is ready in different containers to apply during the hair transplant surgery. I used the PP, it was 2004, probably that photo. I used the storage solution here, and this is after you do the gel and activate with thrombine. You activate the platelets, and you can see gel, and then you can soak the graft and place those grafts, and also you can apply in the recipient area. You can see here, this is for the donor area. It was a donor strip case. We applied here the gel, the platelet-rich plasma, and then after the suture, that part of the patients, and you can see this is the placebo, and then you can see a little messy with too much redness, cross, etc. But you can see the same thing with this particular patient, but it cleans very fast and help. This is the patient with the PRP and this area in the recipient area that heals faster. And then the results, what we saw, well, speed up the wound healing process, decrease redness and scalp formation, decrease postoperative pain, decrease the anagen and telogen effluvium of the transplanted hair, and faster growth of the transplanted hair. And we present this at the ABHRS 2005 in Sydney, Australia. This is just one of those patients that actually not part of the study, but we applied here the PRP and PP, and you can see the recipient area, and then the donor area with good scarring. Another patient 4 months later, you can see the hair grow faster after the treatment with the PRP. And the conclusion of the study, the growth factors accelerate the wound healing after hair transplantation. Is the patient on blood, no risk for HIV or hepatitis. The centrifuge, automated centrifuge, better for platelet recovery. But it's important, similar results in the donor and the recipient areas at 12 months between the PRP group and the placebo group. So what happened just helped at the beginning of the wound healing process, the first month, 2 months, but later on it's going to be pretty much the same results. And that is not a substitution, the PRP, of a good surgical technique. And it's a technique, the PRP, that help you to enhance your hair transplant results. And now talking about the job, with that in mind, we go to the next. Is going to be the PRP for hair loss. This again mentioned increased popularity the last 10 years, probably with too many multiple studies with different results, with different machine, different devices. But the thing is pretty much all show some hair, increase the hair density and hair diameter. I think is want to mention about the study. Dr. Sarah Wasserbauer mentioned some issues last week too. And I just mentioned how is the follicular effect of the PRP for hair loss? That's what is important for us. Number one, because increased cell proliferation and differentiation, prevention of apoptosis, accumulation of B-catenin, angiogenesis improvement, promotes telogen to anagen transition, and prolongs the anagen phase of the hair follicle. This is courtesy of Dr. Lynn Goldberg. Just the technique, obviously we harvest, we do the blood draw, and then the centrifuge for separation and concentration. Then probably going to activate or not activate your PRP, and return you inject in the scalp. How deep it's going to go, they're different. I usually go a little deeper. I go to the depth of the dermis, or many times in the subcu. People recommend a little more superficial. And this is probably waiting for the results of this particular device and everything. But again, PRP protocol for hair loss can be very different because the technique is different. The patient is different, the technique is different, and we are different for what we're going to do. So the quality of the platelets are important. The machine, I just mentioned how important it is. Anticoagulant, are you going to use anticoagulant or not to obtain the platelets? How are you going to activate the platelets or not? The depth of the injection I just mentioned. The distance between the injections, it's very important too. I'm going to show a graphic. And the frequency of injection is going to be every month, every 2 months. How often is going to be, often you're going to inject in the patient every month for the first 3 months, and then every 6 months. That you need to make a plan for the patient and the maintenance. If you have good results, probably the combination treatment will help the patient very well. This is a patient courtesy of Dr. Jeffrey Rappaport. He 25-year-old male, and 6 treatments, and you can see very good response with the PRP, but this is what we have for the injection pattern. It wasn't too close. I followed that thing for 2 centimeters in between for the injection, for a little more. And this is the template that usually we use for the patients, not very close as we did in the past, and go a little deeper in the injection too. And again, the combination treatment is much better with the PRP, hair transplant surgery, Minoxidil, and Finasteride. And you can see this patient and I saw after 1 surgery, you can see it doesn't look natural. The hairline is that you see the 90 degrees angle here in this area, and diffuse hair loss from the front to the back. And the patient asked me my opinion. So I recommend immediately, obviously, Rogaine, Minoxidil, Finasteride, and the surgery. And each surgery, we have 2 surgeries. I inject during the surgery the PRP with different device, inject here, and you can see the results with 2 surgeries and 2.5 years later. So we have good, looks natural, and also they have good density in all the areas. Probably here required to maintain all the case with the treatment. Another alternative treatment for endogenetic alopecia obviously will be that have been discussed, and we discussed last week actually, adipose derived stem cell and hair loss. And I think it's important to mention that the fat tissue is recognized as biologically dynamic complex tissue. And then we have influence in different things, the adipose tissue in growth factor production, angiogenesis, immune modulation, anti-inflammatory purposes, endocrine, and source, that's important, of stem cells. This is Patricia Sook in 2002. She described this. And then we have Festa in 2011 that the fat in the scalp may play a role in hair loss and hair growth. And he reported that the adipocyte cells support the follicular stem cell niche and the hair growth cycle, from the telogen to the anagen with the fat. Talking about the adipose-related terminology, that's very important because now we hear stem cells, adipose tissue, the stromal vascular fraction. So if we aspirate, thank you, Mugiz, for deleting your, thank you. Aspirate the fat, we need to be very careful because which cannula we're going to use, we can traumatize the fat, and the cells that we can obtain will be different, but we can get adipocyte, blood vessel cells, macrophage, and a little percentage of stem cells. But we need to process that fat, we need to wash, and then we can have the digestion enzymes. We can use collagenase, we have trypsin, and we can get what we call the stromal vascular fraction with different type of cells, and increase a little more about stem cells with that stromal fraction. And the other part obviously will be the culture of the stem cells that we're going to talk about. This is a lab, it's very costly. It's something that we don't generally obviously do in our offices. But the important of this is the stromal vascular fraction, because this is an heterogeneous group of cells that can be extracted from adipose using the automatic devices and have been shown to improve the viability, how the transplant take of the grafted fat by paracrine mechanism to support adipocyte viability. And they have different type of cells that we're injecting for, in this case, for hair loss will be stem cells, even going to be probably up to 10%, some cases it depends, endothelial cells, blood cell, etc. We can inject to the patients to improve that area and the take about the transplant of the cell. But here, for example, it's too many applications that we see right now in the specialties and also different diseases that I'm going to mention one by one, obviously, but the scleroderma, breast augmentation, we saw more cases of buttock in plastic surgery. We can use more for buttock augmentation, also breast augmentation as a filler with a nanofat, for example, we can use, etc. We can use many things, including alopecia. And I'm talking about alopecia. This is the European proof of concept study that the fat is the treatment for pattern of hair loss. It was a regeneration study to evaluate the role of purified lipoaspirate plus the stromal vascular fraction in treating hair loss patients with male and female pattern of hair loss. We did a study with Dr. Sini and Dr. Sforza Daniels in 2004 in UK. So we get the stromal vascular fraction, as I mentioned, the technique, and to inject that particular patient. I'm going to give more in detail with this, because the key is the technique. Again, I mentioned the liposuction for this particular process is very important. We don't want to traumatize the fat. We need to use very gentle with the cannula, which type of cannula we're going to use. And the location is not the same to get fat from the legs, from the thighs, versus the anterior part of the abdomen of the flanks. Here, these areas are much better quality for the adipocyte and also for the stromal vascular fraction. And the process continue again to wash the fat, to digest the fat, to obtain what we want, the stromal vascular fraction, and inject in this particular case for hair loss into the deep dermis and subcutaneous adipose layer. This is injecting here in the hairline for the patient. The results, just to show here, that we include 9 patients. It was just preliminary study. We had 9 patients, just 6 finished the study, and average the patient 60% increase in the hair counts versus 6 months baseline versus 6 months later. So There is no side effects, and all the patients demonstrated some degree of response, but it was one treatment only. So the patient will need, obviously, several treatments to continue the maintenance, and I presented this 5 years ago at our Chicago meeting. This is just to show one of the patients at 6 months, global photography. This is the baseline of the patient, and this is 24 weeks later. You can see some improvement, very light improvement, but at least stable hair loss and some regrowth. This is another patient with the study that show a little bit of improvement in some areas here, and maintain what they have. The patient didn't lose hair and gave some small amount, at least some percentage of hair after the 6 months with the treatment. We published the article. I gave you a copy of that too. And the initial data experience demonstrated that scalp stem cell enriched fat grafting may represent a promising alternative approach to treating baldness in men and women, but obviously further research is needed. And with that in mind, the company did another study, multi-center study, with Dr. Ken Weshanek, the principal investigator, Dr. Varanovis, and Dr. Epstein. They were investigators too, with the role of that adipose tissue in treating pattern of hair loss. It was similar to what we did in the first study. It was probably the second multi-center study. They include, 70 men and women with androgenetic alopecia, and they compare different type of treatment with the SPF, stromal vascular fraction, versus adipose tissue alone versus saline. This is the results after, for example, this is 52 weeks later. You can see the hair is growing, good result with the hair counts at the 6 months, and then start to decrease. Because obviously they need some maintenance. So, and the placebo, you can see here, down and negative until the finish of the study with the other different responses of the other treatments. This is courtesy of Dr. Kuka. There is some before the treatment, and this is after the treatment. You can see some response in those specific areas in the mid scalp. This is another patient for the crown. The injection here, you can see the thinning, and then a little more regrowth, and there you can see the hair is taking the pigment after the treatment. Another group, my good friend Dr. Prasant Farjo in England is working with this project. Hopefully we will see something in the future. Hair clone, hair rejuvenation. I'm going to talk too much about this, just mention the biopsy, the banking, expanding, implanting, and rejuvenation. This is one of the goals, and hopefully soon we will know more about this from Dr. Prasant Farjo and her clone. And you are familiar probably with the French fry hair connection. It was 2 years ago in the news, breaking news that French fries regrow hair. It was in the news when it was a Japanese, actually they did the study, but when you read the study, it was in mice. And it was difficult to extrapolate those to men because everybody's saying you need to eat French fries because you're gonna regrow your hair. So, but that's not true. And this is part of the component, the methyl polysiloxane, that that's the way, that one of the ingredients to make the French fries. Even President Trump in the US mentioned a few weeks ago that said his hair growth is related to the French fries. It was another connection there, but the reality is not. No, it's not yet. We will see if they can do a study, because we cannot extrapolate animal studies versus human. So that's totally different ball of game. And we need to wait if we're gonna do something. French fries, grow hair in men, it's a silly thing. And just to mention, just to finish, prostaglandins and hair growth, we know about the bimatoprost for eyelash. It's looking the Lumigan for glaucoma, and this 0.3, a solution twice a day. And with this in mind, the company, they tried to do a study, Allergan, actually we did a study with them, with Matt, Dr. Levitt in 2007, I think, but probably the result didn't like the company, because I don't think they never published the results of this. It's what I mentioned. Hopefully another company will retake this, and we can see some results with the prostaglandins. JK inhibitors is another for androgen alopecia. Clarity was a company, was doing some topical and oral for alopecia, and at the end, something happened and finished the study, but this type of medication has been used for alopecia areata with good results. So just to finalize, probably many hair loss research studies are going on right now. That's a good thing. Hopefully we will see more options for our patient in the near future for hair loss and hair restoration. Thank you for your attention.
David, thank you very much for such an amazing lecture. You covered each and every part of this topic, you know, non-surgical medical treatment of hair restoration surgery. I have so many questions to ask.
Yeah.
I don't know from where I should start.
Yeah, probably if you can check, read, and select what I will be the best thing to do.
I just want to know do you have any experience in Botox? I have just read 1 or 2 papers that they were treating mesotherapy of Botox in scalp for hair growth.
No, to be honest with you, I don't have any experience. I think Sam Lam mentioned something last in one of our chats, I think, but no, I don't. I have seen some, but no. Personally, I have not tried first until I read more information. No.
And what about hair bulb stem cell, in which they regenera kind of thing, in which they crush the hair bulbs, take like 100 or 200 grafts, crush them and inject them in the scalp? Do you have any experience with that?
Well, you know, that's a good point, because I thought 2 years ago they approached me in Spain for this device. I read about the information articles, but I wasn't being convinced that taking a little piece of tissue, I think 2 millimeter punch biopsy for the occipital area, and then put in the blender, obtain some cells and inject, and they're going to give you some hair growth. And then I was one of the reviewing an article in one journal about this topic, and I wasn't convinced, to be honest with you, with the photos, what I saw, because we know how to evaluate studies. Doing the studies, you learn how to evaluate another studies for other colleagues, and I didn't. So I don't use people, they using, they saying good result, but I'm not using.
My question is that
I'm using that, and the one thing which all of my patients who were treated by with that, they say one thing, that their hair loss, number of hair fall and hair loss, that has reduced dramatically. But anyway, you are an expert in that. Rana Irfan, you want to ask something? Please switch on your speaker.
No, Dr. Hanif is asking some question.
Okay, Dr. Hanif, please.
My question is that I have seen some people treating the hair loss with the monothreads. Dr. David, do you have any experience with the monothreads?
With a mono what? Excuse me, sorry?
I have seen some people treating the hair loss with the monothreads.
No, I don't know what is, to be honest with you, what is that? No understand.
Rana, Dr. Muiz, can you help me?
Monothreads are basically PDO threads.
I haven't heard this kind of thing actually, what you are asking. If you can explain your question.
Monothreads are basically PDO threads, but I also never heard about treating alopecia with the monothreads. Monothreads are basically used for facial rejuvenation, for wrinkle treatment, but never heard about treating them with, for baldness.
Okay, I don't have any experience now.
Oh, yes. David, I have a question for you that is asked by Dr. Nadeem Umar. And he says, like, if you can explain, how do you prepare the
Adipocyte injection.
Let me see the exact question actually. Dr. Nadeem, are
Adipocyte
you
injection.
here?
Say again, I couldn't, sorry. I missed a question.
Yes, I'm here. Basically, what I
Yes,
asked was,
can you ask any question?
Oh,
yes, I just wanted you to explain a little bit in more detail how you prepare the adipocytes for injection after you have liposuctioned them.
well, obviously they have a process, they have a machine. They have several machines. You have the fat, and then you need to wash. They have the machine, they have some areas for wash the fat. You need to wait at least, I think 1 hour and a half, the machine that we use. And then you have the enzymatic with collagenase and trypsin to obtain the stromal vascular fraction. There are several devices, and each device had different guidelines to obtain the fat. For this device, again, we first of all, we decantation, and then we wash the fat. We have a device we close to the machine, and then the enzymatic digestion with enzymatic purpose for the fat to obtain the cells with the stromal vascular fraction. This is what I have with that device and inject. There is no nano fat, obviously we have another. We try to be, I think the important for this, and I mentioned the cannula, be very gentle, very careful, because the trauma, we saw some studies that showed some trauma to the fat, and the quality is not going to be the same. So that we need very, very concerned for that. And also, you can see some patients that you do the fat, you do lipos also, you can see a lot of grease, you know, a lot of grease, and there is not too much fat. And for this particular device, you need minimum, I think, 120 cc's of fat to process for this machine. So this is what I know for this machine, but another machine, they have different options. Yeah.
May I want to ask another question? You have explained very detailed regarding the PRP. My question is that what will be the interval between 1 year in between two PRP? What is your criteria? First PRP, when the first PRP, when second, then third, then fourth, then fifth, during 1 year?
Can you say that, Amin? Because his microphone is always cutting. I can hear the.
He is asking about the gap between two PRPs, and how many PRPs would you recommend in 1 year?
Well, that's a very good question. Usually, I try to recommend the patient every, for example, baseline, 1 month, 2 months, 3 months, 6 months, and one more 6 months later will be six times in 1 year.
That's fine. Okay, now the thing is, before I would like to share a screen, I would like to thank you everyone.
I think a comment from Dr. Ginsburg. We have a comment. I think, no? I think so. Dr. Ginsburg, okay. You have
Yes,
a question?
please, Amin.
I want to ask just one question. Is there any role of shower of PRP after hair transplant? Once we finish the hair transplant, can we shower the PRP solution over the newly implanted graft? It will help, or better to inject it before? Which will be the better in
Well,
recipient as well as in donor area?
Well, they have now. I changed my plan, because in the past it was different. You did a suck in the graft, activate, and now what I do, it's inject the PRP before even making the recipient sites. It's what I do: inject the PRP before making my recipient sites. It's what I do now. This is what I do. And again, I do the patient come back again 1 month later for another session, second month, third month, 6 months, and 1 year. It's what I do.
Before closing up everything, I would like to announce one thing, that next week on 14th of this month, Dr. Konstantino Anastasky will be giving you a lecture on designing a natural hairline in men and women. And other topic will be complications, how to avoid placing disasters. And
Can
yes.
I make a comment?
Yes,
Yes.
David.
Well, here, Dr. Alex Ginsburg has a good question. He has a woman, 30 years old, with female pattern of hair loss, and he asking about the oral treatment and the recommendation. Usually, what I recommend my patient is start with 0.5 milligrams and increase the dosage. Any potential side effects, I'm very picky about those things, so I start with low dosage, sometimes go to 1 milligram to 1.5. It depends. That will be my answer for Dr. Alex, and thank you for the question. And thank you for my Spanish colleagues that join. Thank you very much. Gracias a todos. Thank you.
David, well,
Yes.
thank you very much for your time for this lecture. On the behalf of Hair Restoration Surgery of Pakistan and a lot of senior colleagues who are present in the forum, Rana Irfan, Dr. Hanif Saeed, Dr. Fareed Ahmed Khan, Dr. Waris Anwar, and all of the other colleagues who have joined from all over the world in this forum, I want to present you with a small token of love. And here it comes. I want to share it. I will email you this as well. And we actually in person cannot present you this, but online I am presenting you this small certificate of appreciation for your effort and for your time. I hope all of you can see it.
Yes, yes, I can say it. Thank you very much. I really, sorry, go ahead.
Yeah, you are an amazing. It was an amazing lecture for all of us, and we love to hear again and again from you. And David, now over to you.
No, thank you very much. I thank you for inviting me. It really was a pleasure to share this with you. I also learn every time, every day something. And I really appreciate all the guys, my friends that joined today, and you from the invitation, my Latinos, my friends also from Pakistan and the Asian societies. Thank you. Thank you very much.
Thank you very much.
Thank you very much, David. Thank you very much.
Excuse me?
Yes, I just wanted to thank you, David. This is honor for us. You were here, and expert like you is always been valuable to us, and we want to see you again and again in this society.
No.
You see, participation today was touching 60s.